All right. Welcome to Regenix at New Regeneration Orthopedics Back Pain Webinar. I'm Dr. Torrance. We are Regenix at New Regeneration Orthopedics of Florida, serving Sarasota, Tampa, St. Pete, and Orlando. I'm getting on right now. I'm going to share the screen. I'm going to go on mute, but we'll be back in about 10 minutes to get this party started. This year. I'm on that. All right. Hello, hello. How we doing? Dr. Torrance with New Generation Orthopedics of Florida. Dr. Pappas is here. We are gonna get this party started. Dr. Pappas, you can see my screen. Give us a follow for additional information, correct?
Yes.
Fantastic. All right, this is our back pain webinar. Pictures are a little grainy, I'm sorry. So I was just gonna go to this one. All right, and then I am waiting on my colleagues and making sure that they're not in the waiting room. Okay. All right, all right. Did you get a message or anything saying any of them would be tardy or late?
No.
All right. Okay. All right, cool. So, Dr. Probus, do you want to start us off and then I'll kind of navigate everything behind the scenes while you get us going?
Sure.
All right, sounds good. Without further ado, this is my colleague and partner, Dr. Pappas. He's going to get started on our back pain webinar. Again, please, if you don't like and follow us, please give us a like and follow. And we're going to be putting out a lot of really good stuff here the next few months, so make sure you get on there. We'll have some YouTube shorts going and some cool new stuff.
All right. So today we're talking about back pain, and back pain is complex. And what I mean by that is there's a lot of different structures in the lower back. Um, we're all probably familiar with things like, discs and bones, but there's also other joints called facet joints. There's nerves coming off of the spinal cord that go down to the legs that are important, as well as nerves to those joints. There's also an interwoven complex of ligaments and muscles. Next slide. And so the thing that makes back pain complex or can make it complex is that all of these structures are very important to the back. And one of them can cause back pain, but often in people with back pain, it's actually coming from multiple different structures, sometimes the interaction of multiple different structures. And that's why I tell people, it can be a little bit complicated. And so part of our job is to get to the bottom of what exactly is causing the patient's pain. Is it mediated by the joints, the discs, the ligaments, the muscles, or some sort of combination of one or all of them? Next slide. And here's just an illustration of some of the important muscles in the back as well. And again, these all interact with the other structures as well. Next slide. And so sometimes we'll have a patient like the one on the left here. And in this patient, you can see three different levels of the lumbar spine. You can see that the top and the bottom level that we're looking at look fine, at least in this picture. And whereas, it doesn't take a very skilled clinician to spot the problem here, and it's one particular disc at one particular level in the spine. However, the majority of our patients, or I think the majority of our patients look more like it's back here on the left, where you have three different levels, all of which have varying degrees of pathology. They have disc bulging with tearing of the disc in them. They also have some level of stenosis or narrowing of the nerves that come off the back, and some level of arthritis of the facet joints. And so most of the time, we're dealing with an issue more like the second one, where there can be issues kind of throughout the lumbar spine, and if we just address the one level, it's less likely that we're going to get a good result. Next slide. And so the standard algorithm for back pain, typically what the patients will experience is they go to the pain doctor or the orthopedic surgeon, and then they'll be recommended to have either physical therapy, which in my opinion is usually a good idea. I'll never say it's a bad idea. Steroid injections, radiofrequency ablations where they burn certain nerves. Sometimes, if these things fail, they may consider things like spinal cord stimulation, back surgery, or narcotics. Um, and typically, our goal is to avoid the things in red here on this list because they all come with, they can come with substantial downsides. Next slide. So let's dive into surgery first. So there are a couple of very clear indications for back surgery that I think patients should know. One of them is progressing leg weakness. So if you wake up and as a result of a back issue, you're having, progressing leg weakness in one of your legs, that is a good reason to consider back surgery very quickly. The other one with that would be loss of control of your bowel or bladder. Another good reason to have back surgery. Um, this is not the case if you have back pain, even chronic back pain for a long time. And so studies have shown that when you compare patients who have chronic back pain without leg weakness or incontinence to patients who have chronic back pain and had surgery, over the course of 10 years, the ones who had surgery will actually do worse. Next slide. So let's talk a little bit about steroid injections as well. So a steroid is a very commonly used intervention by pain doctors, surgeons, etc., um, in order to try to control back pain, especially for a short period of time. It's a powerful anti-inflammatory medication that you want to put at the site where the patient is experiencing pain, and this is generally a short-term solution. So the cons associated with this are that steroids are toxic to cartilage and tendon. They can increase your risk of osteoporosis, most especially in postmenopausal women. It is immunosuppressive and overall will accelerate the degenerative changes um, in that area that it's injected. Next slide. And let's talk for a moment a little bit about a very common intervention offered by pain doctors, especially called the radiofrequency ablation. This is typically for joint pain in the back from the facet joints, although I've certainly seen it offered to many patients with other symptoms. And when it works great, you can get about 6 months of pain relief for facet joint relief. The idea is you burn a nerve that goes directly to the facet joint, and then so you can't feel the pain coming from that joint. The downside of this is that that same nerve goes to a muscle called the multifidi, which is an important um, rotator and stabilizer of the spine. And we know that multifidi atrophy, which is what happens when you burn these nerves, is associated with back pain in a number of studies. So, especially when the patient is, on the younger side, I really caution people against this because, you've just set a patient up to have less stability from multifidi atrophy long term. Next slide. And I'll let my colleague, Dr. Leiber, jump in here and discuss a little bit about some of the interventions that we do as opposed to the more traditional options. I think you're on mute, Dr. Leiber. There you go.
Yep. Thank you, Dr. Pappas, Dr. Torrance. Thank you for the review of the anatomy and kind of what's traditionally done. Lots of things have advanced over a number of years since we started doing these kind of procedures, and we're seeing better and better results as time goes on with modifications and technique and processing of these things. So basically, for those of you new to what we do, and what we are experts in is utilizing a different type of solution material for injection of different structures in the back. So ideally, what we're trying to do is strengthen tissue, heal tissue, increase the ability for that tissue to withstand various loads so that it doesn't start to get inflamed and painful, etc. So the body already has a mechanism by which it does this. It utilizes its own platelets and growth factors from within the platelets to try and stimulate and recruit other cells to an area to try and strengthen that tissue. So we utilize those same substances from your blood. We can draw your blood, isolate these platelets and these growth factors, and concentrate them into a very high concentration, well above what your body would have in the same volume, maybe 7, 10, 20 times as concentrated, and use that as a liquid to inject these different tissues that Dr. Pappas was describing. That is, ligaments and muscles around nerves, into joints that are arthritic, in discs or around discs, for example. So that's the platelet part of it. The other side, we can also use bone marrow. Bone marrow, once you remove it and concentrate it, you can concentrate different layers that contain lots of healing substances, one of which people have heard of is called stem cells. And so we concentrate the layers that have the most stem cells. We know that platelets the growth factors can attract stem cells to an area. Here we can actually concentrate those stem cells and place that as a liquid. We often, if we're doing bone marrow, combine it with platelets, or we can just do platelets alone, which is probably more common in the back. Let's go on to the next section. Uh, so as I mentioned, platelets and bone marrow, they have substances that promote a minor, small, controlled inflammatory reaction, which is basically the first step and stage toward the rest of healing. So anytime you have an injury or a cut, there's a little bit of inflammation that is part of that process, and that sets up all the signaling needed for the other cells and resources needed to come and be attracted to the area to ultimately, again, strengthen and improve the health of the tissue that's being either injected or in an injury that has been injured. Let's go on to the next.
1 second. Yeah.
So our approach is going to be different than what we would do if we were using a steroid or a cortisone, or if there's an ablation occurring. In those cases, you're very focused at one spot or another spot. Generally speaking, when we're doing a low back or a neck, we're treating a region, we're trying to treat multiple different structures at the same time, and there's going to be some fine tuning, and people are going to have different more significant issues in one spot or another, and we will certainly modify our plan based on that. But in general, we're going to treat around nerves, inside of arthritic joints and the ligaments that support those joints, other supporting ligaments in the area of muscles as well, sometimes the sacroiliac joint and ligaments surrounding the sacroiliac joint, and piece together a plan that's more comprehensive of the region. So you're basically trying to treat the area that you think is causing the pain, but then also try and treat the other structures in the area that support stability and proper movement, and may also be potentially a source of pain. So it tends to be a more comprehensive procedure. It could be that you have a very isolated problem, and then in that case it would be more limited. But generally speaking, we're going to be treating a region. Go ahead and move to the next slide.
Sorry.
And these are just some visual examples of the needle placements. In the upper left, we have an injection. You have a needle that's placed inside of a disc with dye inside of that L5S1 disc, and that dye shows that we're in the right place. Once we know we're in the right place, we can then switch it out and put either platelets or bone marrow concentrate into that tissue to try and improve it. On the right side upper is an injection that shows an outline of the nerve that can be kind of pinched in certain kinds of stenosis, foraminal stenosis, and that shows that we're in the right place there, for example. And just lower left is what's called a facet joint. Those tend to be arthritic, and we inject those. That's the sacroiliac joint that's being outlined by Dr. Torrance here, and we have dye in the bottom part of that. These are ligaments along the side of oh no, those are the interspinous and supraspinous ligaments. Those are midline ligaments that provide support. And then there's a side ligament called the iliolumbar ligament that we inject. So the point of this is that precision is critical. We want to make sure that we are in that tissue. We know what tissue we're injecting, why we're injecting it, and we can modify a plan. Some tissue may get certain concentrations of platelets, where others may get other concentrations, and we piece together a plan that's going to be individualized, but based on a theme of treating multiple different types of structures. I don't know if Dr. Torrance, if you want to take this, you want me to keep going?
Sure, I'll jump in here. A lot of patients who come to see us are coming to see us with axial back pain or radicular back pain or a combination of both. And this study done by our registry data was 13 patients back, axial back pain, half with radiating leg pain. In our full spine approach, where we address the facets, the the ligaments, and all the nerve roots, etc. And what we can see is that in some of the follow-up MRIs that we can get some of these discs. This is a disc protrusion that is resolved after our procedures, and this is another disc protrusion that is resolved after our procedures. What we found was that even in degenerative disc disease, which is this here versus this right here, that we can get patients to get better. This is the visual acuity score for pain. And what we saw was patients went from an 8 to a 0 in pain score, 6 to a 0, 10 to 0, 6. This person was lost to follow-up. Unfortunately, 7 to 0, 4 to 1, 8 to 5, 4 to 0, 9 to 0, 9 to 0, 7 to 3, 7 to 2, 4 to 1. And just showing us that most patients are progressing in the right direction and getting better. And if you don't believe, our registry data, here's another study that looked at patients who had injections and at 1 month, 3 months, and 6 months had a 90.7% excellent response at 6 months. And this was Kirshner and Antua with 86 pains with chronic back pain. So, and another study here by my colleague, Dr. Ambach and her team, they looked at whether patients would do this again and if they were significantly improved or not and satisfied. And over 80% were satisfied and over 80% would do this again. I think these are fantastic studies that just show our platelet-based procedures have very, very good evidence as well as good outcomes data that can back it up and show that we get very, very good outcomes. This is our registry data, again, another looking at our function improvement, and this is over time, really 61%, 63%, 64%. I usually tell patients you look at about a 60% improvement in pain and function typically, and that's what I talk to patients about a platelet-based procedure. What we typically see in our follow-ups and what we see from our patients, and this is what we'll talk about every day, is that disc morphology can be improved. We do see less pain, more function, getting you off narcotics and steroids. What we haven't been able to see yet, and I'm curious to actually ping Dr. Pappas and Dr. Leiber on this one, if disc height changes. We haven't seen that, but there was a recent study that was published that looked at a discectomy coupled with interdiscal PRP injection. And I want to kind of see what each of their thoughts are on that, but 100% efficacy for every patient. So there's some things that we not 100% of the time works every time is not a good, not a doctor that I would work with. Unfortunately, those are the people that are dangerous. And these are the disc changes that we've seen. This is Dr. Lieber's patient. You want to give a little color on that, Dr. Leiber?
Yeah, if you want to go back to the prior slide first. So one of the things people often ask is, are we going to see a difference in the height of the disc? And unfortunately, nobody's really seeing that with these procedures. But what we do see is a change in the health indicators of the disc. In other words, on the left, you could see that this disc is black, which is a sign that it's lacking in hydration, which is a sign of an unhealthy disc. Whereas post-procedure, we can see sometimes these hydration, meaning water fills in the disc, it becomes a healthier, more normal tissue. That is a positive imaging sign and definitely moving the tissue in the right direction. When you go to the next slide, this was a patient of mine. People often ask, can it get rid of herniations or bulges? And in fact, this particular patient, I did not even inject inside the disc. I injected around the disc with epidural platelet injections, which is outside of the disc, but and around the nerve. He had a very large herniation, which can be seen best, I think, on that left lower. There's a big bulge or herniation, a focal herniation that's coming out there. And then after 2 procedures, we ended up getting another MRI sometime down the line, and you could see how it is nearly completely eliminated in that lower right section there, and that made a huge difference for him clinically. And the thing to note is that some people might say, "Hey, these things can go away on their own," and that can happen. It's true, but he had this for about 7 years, and it never went away. All the MRIs showed it And then after 2 treatments, a short time afterwards, it did resolve. And so we can be confident that it was related to the procedure. So he did very, very well clinically. And we have quite a few cases like this, but this was a nice, just sort of visual example of it. All right. And I think that's the last slide.
1 second. You gotta get my. Yep. And so we'll open it up for questions now, and we usually take these live. So I'll usually ping the question. Anyone leave some questions in the chat box. Please make sure to ping some questions there. All right. Question. I'm gonna ask this out loud, and I'll let either Dr. Leiber or Dr. Pappas take it. What level do these doctors go to when doing cervical posterior? Do they start at C2 down, or do they go higher yet? C0, C1. Dr. Leiber, why don't you take that one?
Yeah, no problem. So this is a lumbar talk, but certainly cervical is part of the spine as well. It depends on the person's symptoms, right? So we don't always do, it's not the same thing on every person, but there are times that we can go up to C1, 2. There's potential for going to C01 if necessary, but C1, 2 would be usually the highest that I'll go most of the time, and often we'll start at C2, 3 and go down if but we need to look at your specific situation and understand your symptoms and look at your MRI and so forth, do an exam, and figure out what the best uh, combination of injections would be for you. All right. Any other
All right.
questions?
All right. All right. Any other questions?
I have a cervical procedure coming up here in 5, actually about to start right now. And lumbar after that and hip after that. So we got a busy afternoon, all of
Yeah.
us today.
Yeah. Well, so yeah, did you guys get into that study at all yet? Dig into that one with the discectomy with PRP and getting increased disc height?
Well,
I haven't seen that. Well, I haven't read through it, but my take on this is we've seen these kind of studies in various areas of the body before, and the goal really is to avoid surgery. If we can do this and get people a clinical result that is satisfactory, get them from a place where their pain is really not livable to a place where it's really okay and manageable without having to go through the surgical procedure, we think that's a better strategy overall. So there may be certain scenarios where combining the two could be a good option, but um, first is let's avoid that surgery. I see other questions here. Does
You
your
want me to read it
treatment
too?
help? I was just going to read it. Does your treatment help with spinal stenosis? Dr. Pappas, if you want to answer that.
sure. So there's a couple of different types of spinal stenosis. There's one where the nerve root that's coming off of the spinal cord is being compressed, usually by a disc, but sometimes by a joint or both. That's called peripheral spinal stenosis. And that has a very high success rate. I think the previous numbers that Dr. Torrance were quoting, 60 to 70% in that range is usually what we see. Um, in terms of, there's another spinal stenosis, a little less common, called central spinal stenosis, and that's where the spinal cord itself is being compressed. That is a little bit less, I think, successful, maybe more like 50% success rate, but it depends really on how advanced it is and how severe it is. So the very severe central spinal stenosis is, I think, less likely to have a great result. Mild central stenosis I've seen have very good results. And moderate probably in between the two. And so, it's important when you have an evaluation, you have it with a doctor that kind of goes through and looks at, how severe and how things look exactly, especially on the MRI, in order to really give you like a good sense of your candidacy.
Yeah,
All
I mean,
right.
I've seen some very severe spinal stenosis also do very well at times if in a very targeted approach. We can try and inject the ligaments that are thickened that can create that spinal stenosis. And just had a patient 2 days ago who reports that he's doing amazing, and he had just very, very, very severe spinal stenosis. And so, if for people with spinal stenosis, they can't stand up straight oftentimes, and they have pain that goes down the back of their legs within just moments of walking. So if you can take somebody who can barely stand for 5 or 10 minutes at a time, or walk for 5, 10 minutes at a time, and then they're able to stand or walk for 1 to 2 hours. It's not perfect, but boy, does that make a change in their quality of life. I mean, it changes everything for them. And so I think that is something that is doable, and I think commonly I'll see that. And for more mild to moderate, there can be even more dramatic changes in that.
All right. Does this help with what was the next question? Does this procedure need to be repeated and how often?
So it depends. Most of the time with spine procedures, typically not putting people on like a maintenance type of strategy where we might consider that with something like knee osteoarthritis, where we know that arthritis is a progressive process in the knee, and so we'll often recommend like a maintenance PRP boosters or things like that. In the spine, I think it's a little less clear. The one time that I usually recommend follow up in a year is when somebody has a lot of surgical changes in the spine, because what we can't do with the needle obviously is correct the fact that they have a fusion or that they're missing part of the bones that were removed from surgery. And so in those cases, you have reasons for increased wear and tear in the spine. And so in those patients, I'm a bit more aggressive about recommending follow-up procedures on a kind of a routine basis. Whereas if somebody hasn't had those things, I usually don't.
Mhm. I concur. Dr. Lieber?
Yeah, I mean, I think it varies so much, but the procedures can last many years, and
Mhm.
so we kind of I generally wait till they start to feel some discomfort and they want to come in. I'd say more often than not, the person is coming in for a different problem rather than the
Yeah.
problem we treated in the back. And so I see them again to say, "Hey, how's your back doing?" And they're like, "Yeah, that's fine, but now it's my shoulder." Um, and then so if this procedure lasts you 2, 3 years, it's worth doing. If it only lasts 2, 3 months with 1 or 2 procedures, then that's not worth doing. So we find that most people find that it's worth doing. It's something that
Yeah.
they are happy that they've had done.
I'm going to jump down to, is this a permanent correction? I think we just discussed that here. I think that a lot of times when we have more of an isolated disc issue, it can be more of a permanent correction, but we live life and we continue to live life, so things can happen at any time to anybody. So I would say we can get this to sometimes reabsorb, as we've shown in the images here, but you're not going to stop living and stop doing things. So we're always going to assess and reassess and hopefully get you back to where you want to be. Um, does anyone answer the PRF as well as PRP question?
I can take it if that's okay. So PRF is a slightly different product than platelet-rich plasma. So somebody's asking about whether we would use PRF. We have looked at this before. Regenix has looked at it in the laboratory. I first learned about PRF many years ago from a dentist because they would be able to take the platelet-rich plasma and kind of make it into more of a putty, and they can then form it and put it into like a bone socket or something so that they can get regrowth of the bone, and they can kind of shape it into that hole. The problem is you can't really inject it through a needle very easily. And so it's not that useful for our types of procedures at this time. I think there may be some newer ways to make it, and there might be something we look at more in the future if we can get it into a form that's injectable.
Please elaborate on stem cell treatments and their success rates, US capabilities versus foreign wellness stem cell injections via IV versus targeted injections. I don't know if you were here for the whole lecture. We talked about these things a little bit, but Dr. Pappas or Dr. Lieber, you want to take the rest of that?
Yeah, and I know this gentleman, so I'll say hi, but I won't say his name. Um, says please elaborate on stem cell treatments and their success rates. U.S. capabilities versus foreign. I see wellness stem cells. Boy, that is a big topic. We probably should
Yeah.
have a whole separate, I think, webinar on that. I would say. That's a bit big to kind of tackle right now at the end of this talk. So I would say for this patient who I know and I've known for many, many years, um, who I enjoy talking to, feel free to reach out to me directly, or we can set up a time to talk, and I'll dig deep into those questions with you. I'd be happy to do that.
So anonymous, so somebody, how does this compare to hyaluronic acid or steroids? Dr. Pappas.
So, well, in general, hyaluronic acid is only FDA approved in the knee. So generally, people are only injecting those into the knee and not the back. Also, it's a very viscous substance. You couldn't really fit it into anywhere in the back. Um, but in general, PRP versus, let's say, PRP versus hyaluronic acid, there's roughly 20 studies that have compared the two in the knees. And in those 20 studies, PRP is quite clearly superior to hyaluronic acid in terms of outcomes. There are 5 other studies, though, that have looked at the combination of hyaluronic acid and PRP in the knee, which do show some improvement with the combination as opposed to the sum of its parts, which is interesting. So we use a lot of hyaluronic acid plus PRP in the knee and some other joints in particular. In terms of steroids, generally, so steroids are toxic to cartilage and tendons and some other tissues, and so they can provide short-term relief, usually on the order of days to weeks, at the risk of increasing the degenerative changes in the structures that they are injected in. And so the PRP or bone marrow stem cells are usually the opposite. We start an inflammatory reaction in order to try to improve the joint medium to long term.
Awesome. Great answer. And then Dr. Leiber, I think you probably got to bounce, but I'll ask Dr. Pappas' last question. You got a second, Dr. Pappas?
Yeah, I'm going to
Sure.
take off. I have a patient on the table. So nice talking to everybody, and look forward to working with you if you desire that. Take care.
Dr. Pappas, 26-year-old daughter, 80% compressed disc with calcification on ligaments. Would our Regenix procedures help with that much degeneration of a disc?
So in terms of the disc morphology, the disc looking more hydrated, yes. We can get discs to look more hydrated. We can improve the health of discs. What we can't do is get the disc to be higher. Can't get it from here to here, but we can get the disc itself to improve. In terms of a 26-year-old with calcifications on ligaments and stuff, you would also want to work up other systemic processes like parathyroidism, et cetera, because there may be something else going on systemically that would lead to calcified ligaments in somebody that young. So you want to be sure the thing causing the pain is the disc and not necessarily this other systemic process as well, which would, require a thorough workup.
I agree. I think that that person should come in and see us for evaluation. One of our locations, Sarasota, Tampa, St. Pete, Orlando, and have a thorough evaluation, and see Dr. Pappas, Dr. Velastro, myself, or Dr. Leiber, and we get you on the right way. I would add in that getting ahead of this versus waiting till this is 100% collapsed or compressed would be a good thing, because the more depressed this gets, the less space we have in the foramen. So I mean, I would probably try to stay ahead of this. That's what we try to tell our patients, and that's what we try to. If you have a disc that's out, you're going to have decreased height and problems in the long run. So all right. Well, listen, Dr. Pops, I know you got to get to your patient. I do too. Thanks everybody for coming. If you don't like and follow us, please make sure you like and follow us. Give us a call to schedule an appointment. And thanks for everybody's time.